Hello doctors, welcome to yet another episode of our dialogue web series. And today we are going to see a couple. So how do you approach a couple with a previous Down syndrome child? So either they would have terminated the pregnancy because of Down syndrome, or they have a child which is who is diagnosed with a pure trisomy, or let it be even a translocated Down syndrome. So we have discussed many of these cases in our dialogue workshops, but today in this video we are going to see the practical points what we need to know when we come across a couple with previous child with Down syndrome. So as we all know, in our dialogue series we've always been discussing only based on case scenarios. So in this video as well we'll be discussing about two cases. So the case one, the first patient who came to me was a 34-year-old second gravida. She is at present, when she came to us, for 13 weeks. Previous child, there was no antenatal screening done, but the child is 5 years old, alive, and the child was diagnosed with trisomy 21. Otherwise no other medical or surgical risk factors. So the first time when you come across a couple with a previous baby with Down syndrome, say the baby has been diagnosed with Downs by a pediatrician, what are the things that you would want to ask the couple, or what are the important main points that you want to ask them or look at their previous records? The first and foremost thing is to look at the karyotype of the baby or the child. So most of the couples would have had a karyotype done for the child. So why is it important? The first point, the karyotype is extremely important to know what type of Downs it is, because we have different types of Downs. And why is it important? Because each and every type of Downs is going to give you a different risk factor. So risk, recurrence risk ratio. So that's the main reason why we need to know the type of Downs. So only when we know what is the type of Downs, we'll be able to tell them for sure what would be their recurrence risk for the next pregnancy. So this patient, when she came to us for 13 weeks scan, the ultrasound was normal, CRL was fine, nasal bone was seen, even NT was normal, as you can see in this picture. So then this fetus is structurally normal. Then what comes to our mind next? So what should we do? The options, wide range of options are available these days, because we do have first trimester screening, then we have the option of non-invasive prenatal testing, and we also have the option of a direct invasive testing, let it be a chorionic villus sampling or even an amniocentesis. So as an obstetrician or as a fetal medicine consultant, what should you do next? That will be our first choice. So all these three can be offered to the couple when the ultrasound, that is the NT scan or the first trimester scan, is normal. Now this patient, we offered all the three choices to them. We clearly explained to them what each and every choice would mean to them. So they opted to go ahead for first trimester screening. They wanted to see the first trimester screening report and then plan on either confirmatory test or non-invasive prenatal testing. Now this patient, after coming back to us with the first trimester screening, here you can see very important point what you need to note here in the screening protocol, that's in the blood test. Whenever you give it to the lab has to either you have to make sure that the lab knows, or the lab has to document that the patient is given the previous history of Down syndrome. That's extremely important. As you can see here, the maternal age is around 35 years at the time of delivery, and giving lab the information that the previous baby or a previous child, she's had a previous child with Down syndrome, is very important, because your a priori risk, which is taken as the age risk alone for this patient, will be changed. They'll be including the age risk along with the history of previous baby with Down syndrome, and your a priori risk will be 1:143. More so, we will get this risk only at around 39-40 years of age in a routine mother, but here, because of the previous history of Downs, the age risk is 1:143. So this gives us a very clear information that the history which you provide to the lab is very important, and the lab also should incorporate it while they are doing the risk calculation. In spite of having a previous baby with Down syndrome, all the blood parameters over here is normal, and that's the reason why what we have gotten over here is a first trimester screen, which is screen negative. So this screen negative is around 14,900 odd patients. Only one mother is going to have a baby with Down syndrome. So this is clearly a screen negative report, with everything being absolutely normal. Now, do we talk to the patient on further testing? Most of a couple, when they have a previous baby with Down syndrome, obviously they would want to confirm whether the subsequent pregnancy of the children are normal or not. So even if they don't insist, most often they do. Even if they don't, as obstetrician or fetal medicine consultant, we do offer them. And this patient opted for a non-invasive prenatal testing, and the cell-free fetal fraction DNA was above 8%, and this also came as low risk, and the baby was fine. Now let's go on to the second case scenario, wherein she is also a second gravida with the previous baby with mosaic trisomy. So I told you we need to know the type of Downs, right? Once we finish this case, then we will go in depth about the types of Down syndrome and why is it important. This patient again came for an NT scan. Structurally, the baby was normal. If this baby, the previous baby, had Down syndrome, that's mosaic Downs, will your options differ? It's going to be the same set of options given to this patient as well, whether she can opt for a Down syndrome screening, the first trimester screening, or an NIPT or a invasive testing. So the patient opted for a first trimester screening. She is going to be around 31-32 years at the time of delivery, and yes, we did document that the previous child was Downs, and here again we got the risk ratio. If you can see here, the A priori risk is 1:184, whereas the final risk, even though the Pape mom was around 0.4, the final risk is 1 in 36,000. So we know for sure that this fetus has a very low risk of being Downs. So now we have two case scenarios. One is a pure trisomy and one is a mosaic, wherein both the babies were normal. But we gave them all the options. And why? First, what we need to know, the type of Downs. Why do we need to know the type of Downs? As I clearly explained, depending on the type of Down syndrome is where your recurrence risk will change in the subsequent pregnancies. So then we need to know what are the different types of Downs, isn't it? The first type of Downs is what we call as pure trisomy. Pure trisomy is the most commonest form, that is having an extra one more chromosome, where the karyotype will be 47 instead of 46 chromosomes. So 47 instead of 46, that means there is an extra chromosome of, here if you can see, exactly, here if you can see that there's an extra chromosome of trisomy 21 instead of a pair, there'll be an extra chromosome. So there'll be totally 3 in the possession of 21 chromosome. And for these fetuses, or if these children, if the mother gets pregnant the next time, the recurrent risk is very low. Why? Because it happens because of non-destruction in the meiotic phase. So the recurrence risk is as low as 1%, of course combined with the maternal age. Whereas if translocation type of Downs is what is there for the previous child, that translocation can happen between any acrocentric chromosomes. The acrocentric chromosomes are 13, 14, 15 and 22 versus 21. That means that there's a portion of the 21st chromosome which is getting exchanged with any of these chromosomes over here. That means the recurrence risk would vary from somewhere between 10 to 15%. And if there is a Robertsonian translocation between 21 to 21 itself, that means the recurrence risk is going to be almost close to 100%. So it's extremely crucial that we know what type of Downs it is. And the reason, what is the difference between pure and mosaic Downs, is where mosaicism means we know that few cells, that's majority of the cells, are normal and a few cells are mosaic. That means many cells will contain 46 chromosomes and few cells will contain 47 chromosomes. So that's the basic difference. So but the mosaicism is extremely rare. Pure trisomy is the most common. Translocation, almost close to 96% of Down syndrome babies belong to the pure trisomy, that's with an extra chromosome. 4% belong to, close to 3 to 4% belong to the translocation type, and 1% or less than 1% belong to the mosaicism type. So the finally takeaway points, what we need to know is, when you encounter, the next time when you encounter a couple with a previous baby with Down syndrome, first check the baby. If the baby is alive, then do see the baby, because the Down syndrome characteristics are very prominent in the baby's face. So you can obviously see the baby and diagnose, and along with that, it's not just clinical diagnosis. So you need to definitely confirm it with the karyotype, and once you see the karyotype, see the type of Downs, because our counseling will differ. And the next question will be, can I offer NIPT for a translocated Downs? Because that's a very common question which we encounter, because NIPT might not detect a translocated Downs as much as it could detect a pure trisomy. So what we would prefer, if the parents are carriers or if the previous child is having a translocated Downs, that's the most preferable option is to go for amniocentesis. And for karyotype, if you ask me which is the best present when compared from CVS to amnio, then it would be amniocentesis. And when do you do CVS? Yes, you can definitely do a chorionic villus sampling for karyotype, but if you If you want to have good clear delineation of the chromosomes, then amniocentesis is better for karyotype, and CVS if you want to do say probably a genetic testing, or you want to identify a genetic mutation or any genetic analysis, if you want to have good amount of DNA, then CVS is the better test to do. So for chromosomes it's amniocentesis. For DNA or any genetic mutation, the best preferable way is a chorionic villus sampling. So with a pure trisomy, which is the most commonest trisomy, the recurrence risk is hardly 1%. With the translocated downs, we need to definitely check the parents if they are carriers, and definitely do an amniocentesis, preferable, so that we can confirm that the subsequent pregnancies, the babies are normal. And basic genetic counseling is a must, and that to catch them early if they are able to come to you much prior to pregnancy. And if it's translocated downs, definitely have to test the parents, and it is extremely crucial. If the parents are carriers, the entire protocol of management changes. I hope this video was useful, and please do share it among your colleagues whom you feel that this video would help them in their day-to-day practice. See you all soon in yet another episode of Dialogue Web Series. This is Dr. Deepthi Jammi from Jammi Scans.